why it is that your prescription drug costs so much. But what you don't know is a lot of stuff that's going on behind the scenes.
We had really good competitors like Amazon, and I said it publicly because they forced us to get better. Over 50% of our population, they pay a co-payment, so they don't often see what the true cost of the medication is.
In the good old days, you used to be able to just go around the corner to your pharmacy and pick up your prescription. While you still can do that today, there are tons more options for you as a consumer. Online, mail order, direct-to-consumer and telehealth platforms, all avenues for you to get your prescription drugs. So how do you make all that make sense for you? And what is the best option for you? We're going to break that down on today's show.
Have questions about your health care and not sure where to turn? We give you unfiltered insight into how healthcare really works. This is Give It To Me Straight, Doc, presented by Tampa General Hospital and our partners at USF Health More Sunny College of Medicine.
Welcome to Give It To Me Straight, Doc. I'm your host, Anjalee Khemlani. Thank you so much for joining us today. We're going to talk all about pharmacies and a little bit about this thing called PBMs. But let's start with pharmacies because I've got a guest for you. Former CEO of Walgreens, Tim Wentworth. Thank you for joining us today, Tim.
It's my pleasure. Good to be here.
I'm going to pick your brain on something you know a lot about, which is retail pharmacies. But also, I want to talk about the competition that comes into play with online. This is a thing you know a lot about. You know pharmacies, you ran one. You also know PBMs, you ran one. You're one of the few people that has seen both sides of the coin, and that's really important. So I'm going to actually ask you, in your own words, to explain the relationship between pharmacy benefits managers and pharmacies.
Okay. Well, pharmacy benefits managers really work almost like a group purchasing organization. They work with health plans or large employers or Medicare organizations to essentially build networks that include retail pharmacies, sometimes mail order pharmacies as well. And then they run the administration behind the scenes for those networks. They run the plans that are designed by the health plans or by the employer. So an employer or a health plan, for example, says, we want a generic copay to be $5. The pharmacy benefits manager puts that into place so that when you go to the pharmacy counter, that all happens without you having to really do anything.
And it's fair to say that the PBMs then basically pay the pharmacies. Like that's how pharmacies get their money.
Correct.
And that plays a role in what prices patients see at the counter? What is the reason why I as a consumer can go to the counter or order online and get a certain price and it's different from one counter to the other?
So many pharmacies have something called usual and customary, which is independent from, believe it or not, the PBM's negotiated rate. So the PBMs negotiate with retail pharmacies to pay them some sort of a discount off the cost of the drugs on behalf of the payer, your employer or your health plan. And what may happen is if the pharmacy has a special that particular week, they can give you the cash price of a drug, which may be at times lower than the negotiated price. And it's hit or miss. Things like GoodRx, for example, sort of were created to try to capture and make available to customers that kind of information at the point of sale so they could make the best choice.
So that those entities like GoodRx, like Cost Plus Drugs, that whole Cost Plus model, essentially two different things, right? Discount for pharmacies and then a option where the cost of the list price of a drug is paid and then you get like a markup on that, right? That's the Cost Plus option. So these are ways that pharmacies now have to deal with and contend with as competition almost to the way that they do business. How is that impacting, especially with entrants like Amazon Pharmacy, like Hims and Hers? We've seen huge numbers from those entities, and they're helping consumers and helping patients get access to more medicines. What's the flip side of that?
Sure. The flip side is that for most patients, they're still better off going through their insured benefit. So those alternatives that you talked about, particularly Amazon or Cost Plus, so far
which are cash paying and therefore not part of your insurance typically and so forth. Now there's some changes coming where those things will start counting toward a deductible in a few years and those kind of things. But again, for many people, what you really want your first step to be, you want your first step to be to make sure the drug that you're being prescribed is the absolute most cost-effective drug that can take care of you, which for 90% of drugs is generic.
But once you've made that choice, what you want to then do is look at your insurance and look to see what my coverage is, and then go to visit actually a retail pharmacy, often who will be happy to help you. I know, for example, my company had a thing called My RX Savings Finder, where the pharmacist or the pharmacy tech would run all the different cash programs that were out there to make sure that your cash price wouldn't be lower than your insurance price. And if it was, then we would take care of that for you. We get that coupon or administer that cost. So you still can get a real benefit by going to your retail pharmacy, even if you all end up paying cash.
So now in this system, is that basically there's so many different options, you have to be competitive? Pharmacies have to basically play or work in a world where they know that online exists, and you have to then basically work in a way that gives you money.
When I was running Walgreens, I loved the fact that we had really good competitors like Amazon, and I said it publicly because they forced us to get better, not just be sharp on price, although I would argue we were normally price leaders because of our scale. I mean, scale matters in healthcare when you're buying drugs and you're managing the distribution of them, but also on service. And so, the reason now that you can go to Walgreens and or call us or go online or go to the app, and in less than 2 hours, 90% of the time, you're going to get what we have at your door, isn't just because we thought it was a good idea. It's because we looked at the competition and said, this is where the competition is moving things, whether that competition was Amazon or Uber. Quite frankly, people expect a seamless, immediate experience. And again, though, you want to make sure you're getting the right drug, and you want to take a look at what's my insurance coverage and what's the cash price and which is better, and then make that choice.
Okay. So pharmacies is one part of it. And then we have to get to PBMs as the other part of it. So hang tight. We'll be right back to talk about that. Welcome back to Give It To Me Straight Doc. I'm your host, Anjalee Khemlani. We've been talking about pharmacies, in particular retail and the competition that's out there, why it is that your prescription drug costs so much. But what you don't know is a lot of stuff that's going on behind the scenes, and it has been for some time. There are these entities called pharmacy benefits managers, and Tim, you know a little something about that, having run one before.
I do.
Why don't you just decode it all for us, please?
I could spend a lifetime trying to do that.
You mean you can't fit into 5 minutes?
No, it's really interesting. As you know, I was inside of a PBM for 25 years, and the one thing I always learned was as we brought people in from other parts of healthcare into pharmacy, they were always astonished at how complex it is. And so you can appreciate from a consumer standpoint, it isn't that simple either, and it's gotten more complicated.
And people often don't know what it is.
They don't know what it is. And what they remembered was $5 copays, and I could go into a retail pharmacy. Well, PBMs created that. PBMs wired up the retail pharmacies and created networks so that you could go into any retail pharmacy, show a card, and you could get the drugs that you needed. And, oh, by the way, behind the scenes, would make sure that that drug was safe for you, would make sure that there weren't cheaper alternatives that they could potentially alert your pharmacist, you, or your physician to. So the PBMs played a really interesting role behind the scenes that has had to evolve as new products have come out, duplicate products have come out, expensive products have come out. And so the role of PBMs has continued to have to evolve to try to tame those costs on behalf of the people that actually pay the bills, which is the health plans, the large employers, and the consumers.
Well, the consumers seem to be feeling the pain, right? That's why we're having this conversation. Sure. Because at the end of the day, I guess the concept was that in a world where you are trying to figure out the best and least expensive way to get prescriptions to a larger volume of people, negotiating discounts, all of that was part of the equation. And PBMs essentially collect what I like to call a convenience fee, right? From the system, because they're between the drug companies and the pharmacy. And so at the end of the day, we're living in like an AI world, in a very tech savvy world. I mean, listeners can just go look up PBMs now if they don't already know what they are and get the answer that you could give them. But do you think that in this kind of world, there's a role for PBMs still, or can AI and technology do the work of negotiations, of finding the best price, et cetera?
So I think there's room for both, if I'm honest. I mean, I think the PBMs today, many of them are using AI tools to take a look at things like clinical programming and patient optimization. But quite frankly, just knowing that you've tried a drug and it didn't work for you is something a PBM knows that can be built into an AI engine so that you can almost have a formulary of one. What's going to be safest for you based on what we know? We, years ago, actually looked at trying to take the genomic information that we would have from folks in certain areas for drugs like tamoxifen or warfarin, where you would be titrating, or it might be, in the case of tamoxifen, not appropriate for you genetically, and factor that in. The role of pharmacy is so key because it touches the patient, touches the provider, it leverages all of that data, but I don't think you're ever going to take the humans completely out of it, because at the end of the day, as much as people trust AI, they trust their physicians more, they trust their pharmacists more, and the role that PBMs can play in helping that physician, as well as the pharmacist, whether it's a Walgreens pharmacist or a CVS pharmacist or an Amazon pharmacist, make sure that it's the right thing for that patient, meaning safe, most cost-effective, and everything else. There are AI elements to that, but there's also human elements to it.
Well, and that's the part about the pharmacies too, right? Is that you do have to have someone with the clinical knowledge, if
Sure.
you want to say, the drug knowledge and the interactions. You want them to be able to give advice. So when PBMs are in the background kind of controlling who gets access to what, that disrupts that cycle. And that's been the problem with the current health system. So I know that at the federal level, they've been trying to do away with that. They've been trying to get rid of PBMs, if you will. But there is new law that kind of changes how PBMs operate. What is the end result for consumers? How should we be thinking about these new changes? Will we see lower costs in our drugs?
So I think it's good news for consumers in a very indirect but important way. So if you look at PBMs, drug trends over the last 20 years have actually been very, very managed. We've added 50% of all drugs are now specialty drugs or biotechnology drugs, and we've afforded all of that because the net cost of the system has been managed by the PBMs. The challenge has been, it's been in a high deductible plan environment where the patient is paying a percentage or all of the list price of a drug, and the PBM is collecting a rebate on the drug that was going to the plans. And the plans were using that to underpin the cost of the insurance rather than the patient cost of the drug. The changes that have recently been made both by the government and by some of the large PBMs ultimately create a framework for that money now. If you're on a drug that has a high rebate, instead of you paying that high list price, you would actually see that rebate come into your copay at the counter and meaningfully pay less. And the good news about the government doing that is all the plans will have to accommodate it, because I think no one plan was going to make that change and say these high deductible plans have created an unintended effect for consumers, and that is causing them to not take their drugs sometimes, which is more expensive to the system. And the good news is PBMs have had frameworks for, frankly, 15 years. We had built it 15 years ago at Express Scripts to literally put rebates at the point of sale. The payers didn't want it because they wanted lower premiums for everybody. That's what's changing, and that's good news for people who are taking drugs that have a lot of rebates, because those rebates will now, over time, find their way to the point of sale.
So bottom line, we're probably going to see lower costs, at least for prescription drugs. Are there any negative potential impacts to this?
So I think the system is going to have to sort itself out in terms of how do you create competition where you have multiple therapeutically equivalent alternatives. Super important things PBMs did. Look what happened with hepatitis C in 2016, 2017, when AbbVie put out their drug, the PAC, and it took the price of curing hepatitis C from $100,000 to $120,000 down to $30,000 in a month. And that was done by the mechanics of creating competition. We will need to still create some sort of a guardrail or mechanism to ensure that pharma is in those areas where they're not truly innovating, but where there's Me Too and other things, where they're having to compete on price. And if it's not an after-the-fact rebate, it'll need to be lower list prices for volume or for clinical effectiveness. I also think there is room for PBMs to be a chassis for pharma to guarantee the outcomes of their products. We saw some of that over the years. But if you're a patient and you pay for a drug and it ultimately doesn't work, PBM can actually play a role structurally of helping the pharma company give you back your money. And I've always believed that would also need to be a part of the system.
Yeah, it seems like there's still a lot more innovation that can happen.
There is.
And needs to happen, because this is unsustainable. All we know is that when we go to the counter, we don't want to pay the cost of our drugs. And we are looking everywhere. We can see the trends of online pharmacies cropping up because it's just easier to pay out of pocket in some instances rather than deal with the whole insane network that you understand really well and no one else does. Tim Wentworth, former CEO of Walgreens, thank you so much for joining us.
Thanks, Anjalee. Great to be with you.
Don't go anywhere. We're going to dive in deeper to pharmacies and how they make money next. Welcome back to Give It To Me Straight Doc. I'm your host, Anjalee Khemlani. We've been talking a lot about pharmacies, PBMs, the whole nasty mix of what goes on behind the scenes, but I want to help break it down in a way that'll really, really open up your eyes to what's going on. And that is going to be with Bill Hepshire, founder of Canadian Med Store, and Scott Fritsch, who is a pharmacist at Davis Island Pharmacies here in Tampa Bay. So we've got some local talent on the docket right now. But that doesn't mean that it doesn't apply everywhere. And that's kind of where I want to begin, which is there's a basic foundation to how pharmacies operate today, right? We've seen the way that it works. Basically, insurers have as part of their plan design the drug prescription component. And that plays a role in pharmacy benefits managers who then decide what price they're going to get for the pharmacies, right? And then that is how you end up paying for it at the counter. So these are three of the players that are involved in this process. Bill, I want to start with you and kind of understanding what is it that patients really need to understand about why their prescriptions are so high and why they shouldn't come yelling at you about it?
Yeah, well, we hear all the time from patients who, walk into the local pharmacy, and sometimes they're upset with that, community pharmacy saying, they're making so much money here. And I usually tell people, listen, that's not the case. The community pharmacy is not making all that margin. I compare it sometimes to the price of gasoline. When people talk about the price of gas is so high and then want to blame it on the local gas station owner, that local gas station owner is making pennies on the gallon of gas.
That's a brilliant analogy. I've never heard that one before. That's
same
good.
Thing with community pharmacies. Community pharmacies are not the ones that are making those margins. Sometimes you'll hear stories, and I'm sure Scott can speak to this, where sometimes it costs the pharmacy money to fill a prescription. They're actually getting less. They're getting less reimbursement from the insurance carrier. The PBMs and the carriers are negotiating these prices down. And I think the other big issue, quite honestly, is that the average individual who has group health insurance, and that's over 50% of our population, they pay a co-payment. So they don't often see what the true cost of the medication is. So we talk about all the time, the reason why health insurance is so expensive is because healthcare is so expensive. On the back end, that individual filling a prescription at a local pharmacy doesn't really know what the true cost is because they're paying a co-payment. So it's the employer or the taxpayer who then's really footing that bill for the entire cost.
Right. And I know that I've covered this over the years in terms of having that negative reimbursement, right, is the way it's described in the industry, which is basically you're losing money. So the pharmacy may be selling you the drug, you may be paying 15, 20, 50, 100, whatever it is, the price, but still you won't be making money on that. And in fact, that is putting you in the hole.
Losing money.
Yeah.
I mean, sometimes it's pennies, sometimes it's $10, $50, $70, $100 or more. Yeah.
So imagine every time you made a sale, you didn't make money, and instead you lost money.
That's per month per patient. And imagine what kind of, situation that puts us in, especially as a small independent pharmacy.
Right, and that's different from retail, which we heard previously, right, from about the retail situation from Tim. And so looking at the independent pharmacy, what would you say is one of the key differences between the way that independent pharmacy is paid and a retail pharmacy is paid?
So independent pharmacies and retail pharmacies, the flow is the same. However, there are contracts. Usually, they're multiple pharmacies get together and try to do a contract. But oftentimes, they're not as favorable, and that definitely brings it into makes it more difficult for us to make sure we can keep things going.
And it's hard for you to compete because the retailers have so many locations.
Right.
So it's basically
and buying power and whatnot.
And I think what's so important to understand too is that often the insurance carriers own their own pharmacy networks or own their own PBMs.
That's the whole vertically integrated idea.
So we talk about the misaligned incentives all the time. Does it make sense for that that insurance carrier who you would think would want to lower the cost, but if they own their own PBM or their own pharmacy network, does it make sense for them to refer that business over to Scott, who could actually lower the cost for that Absolutely. Individual? Well, no, those incentives don't align where they want to refer that to someone to actually lower the cost, because again, they own the network and they own the PBM. So
it makes it less competitive for a pharmacy like Davis Island to essentially compete.
It's like playing a sports game and the referees also own the other team.
I love these analogies. Yeah. Okay, you guys are just gonna like write analogies for the show. I'm hiring you. Okay. Bill, I want to move a little bit away from just the basics of the pharmacies and also talk about something that you're pretty good at, and you've made a business out of this for more than a decade or two, and that is importation of drugs from Canada. Like the name of your store says it all. I know there's been a lot of talk about that. You know, in other countries, it's cheaper. We've talked about international reference pricing. I'm not even going to go down that road because there's so much we could cover there. So let's just bring it back, stay local. Talk to me about why your business, no offense, but it's still in business, because the cost of prescriptions continues to go up, or it continues to be unsustainable for patients.
Yeah, so we opened our business 23 years ago, and quite honestly, when we opened, we didn't think we were going to be here 23 years later. We thought that something was going to be done with the U.S. healthcare system, that we were going to lower the cost of
You know what's funny,
care.
by the way? You and the co-founder of GoodRx have both said the same thing to me, that you want your business to go out of business,
right.
but the U.S. healthcare system is so broken that you can't.
And I say all the time, if we actually go out of business because we lower the cost of prescription drugs for Americans, that's pretty darn good. I'll go out and be a bartender or a podcaster. But 23 years later, not only are we not only are we still in business, but we're growing every single year, and that's simply because when you look at the cost of those high cost prescription medications, they're so much less expensive from a country like Canada or the UK, Australia, New Zealand for the exact same medication manufactured by the exact same manufacturer, and folks can order those medications from a pharmacy in Canada. A guy like Scott, unfortunately, is at a disadvantage with that because he has to source his medications through a domestic source, and that means that the pharmaceutical company and the PBMs are continuing to keep that price so high. I think what's also important to know is that we've been doing this for 23 years, but for decades, people that lived in Maine and Michigan and Vermont have been driving over to Canada to get their prescriptions. Yeah. So it wasn't like I was some business mastermind.
You just brought it down south.
All we did is said, shouldn't people that live in Tampa, Florida have that same availability to those lower cost, safe, affordable medications from Canadian pharmacies that somebody who lives in Detroit can drive over to Windsor and 20 minutes later be sitting back on their couch but saving 80% on prescription medications.
So what would you say then to both of you? Quick sort of end to this, which is, I'll start with you, Scott. What is the one thing you want patients to know about how to price their prescriptions before they come yelling at you about their drugs?
The biggest thing, ask the pharmacist, but the pharmacist does this all day and that's what they do. Unfortunately, we can't always give you the answer because we don't make the pricing rules. Believe it or not, the insurance companies do. The insurance company is a source. Sometimes we have the ability to tell you, what it's going to be or approximately, and we can help you. We can always guide you through that process. But I can tell you a cash price, which sometimes is cheaper than the insurance price.
That's the secret. That's the secret people don't know.
But
ask the
pharmacist.
Ask the pharmacist. Ask for the cash price, and ask for potential discounts. Right, like the drug manufacturer websites
potential
also.
Discounts, or just ask. I know the pharmacists are running around crazy. Looks like you don't want to interrupt them, but they will spend the moment with you and just say, "Is there anything we can do to bring this down?" They're happy to help. They may not look like it in the moment, but they're happy to help.
Good to know.
That's what they do.
Good to know. And Bill, what would you be?
Yeah, I think I'd say the same thing. I think that when you look at things like GoodRx and Mark Cuban's Cost Plus, I think that those tools didn't exist when I started my company 23 years ago. They do exist now. So individuals can actually do some research and find, is their copayment, is their insurance actually the best option for them, or could they go to someone like Scott and get that for a lower cost at cash only. I think the other big thing that we have to address is that understanding that over 50% of our population gets their coverage through the employer
Insurers,
market.
yeah.
The truth is employers really have to start engaging more with their consultants and with their carriers to say, what other options are there to truly lower cost? And I know that's difficult because remember, the employers are building widgets or running school districts or running a manufacturing company. They don't specialize in healthcare. They're relying on their consultants and their brokers to help them make those decisions. But I would say look outside the box. Start talking to some innovative consultants out there that are looking to bring in international, looking to bring in relationships with community pharmacists, looking to bring in direct primary care, things like that, where we can actually engage that employee at that level, keep them healthy by getting them access to the care they need, not waiting until they've avoided that care because they couldn't afford it, and now we're in a situation where it costs us so much more as a system to treat those people when they're really sick.
I love that. Okay, that's
Versus
really
reactive.
right. Okay, well, that's been very insightful. Thank you. I hope our audience walks away with some insight into how to get better prices on the prescriptions. That will be from Scott Fritsch, pharmacist at Davis Islands Pharmacy, and Bill Hepsher, founder at Canadian Med Store. Thank you both so much for joining me.
Thank you so much for having us. Enjoy the conversation.
Today you've learned a lot about pharmacies and pharmacy benefits managers and all sorts of reasons why your prescription drug costs as much as it does. Hopefully you walked away with some tips. Don't forget to scan that QR code and join us next time. I'm your host, Anjalee Khemlani. You've been watching Give It To Me Straight Doc.